Hello, everyone. It's my pleasure to welcome everybody to tonight's webinar. My name is David Baumschott, and together with Jason Fisher, co-chair for the RFS Communications Committee. On behalf of the Society of Interventional Radiology Resident Fellow Students section, thank you for taking your time tonight to hear this webinar on interventional radiology in global health. Before we begin our session, I want to remind everyone that this webinar will be recorded and will be available on YouTube by searching IR Education. Feel free to ask questions at any time. You can enter them into the chat box on your channel and we'll keep track of them and answer them during the webinar or at the end. Check the RFS website regularly for upcoming events and follow us on Twitter and Facebook for other updates and posting of clinical material. Without further ado, it is my pleasure to introduce John Moon, who will introduce our speakers and give some additional information about tonight's webinar. Go ahead, John.
Hi, thank you. So tonight we're going to be speaking on the topic of interventional radiology in global health. About it, but it certainly exists, and there are active efforts within the global health domain by interventional radiologists. And our presenters today will provide depth to the topic by offering and perspectives. With that, our presenters today include one attending and two fourth-year resident physicians. So our first presenter will be Dr. Jessica Stewart. She's currently an assistant professor of radiology in the Vascular and Interventional Radiology Department at the University of North Carolina School of Medicine. She has also taken on the role of faculty advisor to the SIR-RFS Global Health Committee. We have Dr. Fabian Lajgo, who is an IR PGY4 at Yale New Haven Hospital, as well as Dr. Robert Peng, who's a radiology resident, PGY4 at Montefiore Medical Center. So with that, Dr. Stewart.
Okay, thanks. Can you guys hear me?
Yes.
Okay, great. Okay, thanks everybody for logging on tonight. I'm excited to get to share some of my experiences working in Kenya on issues related to radiology and interventional radiology in particular, and kind of how we can move forward in the future with some opportunities in that realm. Sorry. Okay, so I just want to talk a little bit about kind of how I got involved in this initially back when I was a radiology resident. So I'm going to go through kind of my first visit to Kenya, which was back in 2014. I actually lived in Kenya for 2 months back in 2016 when I was a fourth-year resident. And then I went and had kind of a focused experience in interventional radiology in 2017. And then we'll go through kind of some of the challenges and opportunities related to IR in Kenya and some future directions. So when I was a second-year resident, I was actually approached by an attending who was planning a teaching trip to go to Bulawayo, Zimbabwe. We were there for a couple of weeks teaching primary care doctors and surgeons how to read various types of radiology studies. In this area, there were 2 private practice radiologists serving a very region of people. So basically, a lot of these providers were reading their own studies. This is one of the lectures that I gave. A lot of these were completely packed. So you can get into this early on in your residency career if you look for some opportunities. There was another group that we gave a lecture to on chest X-ray interpretation. This was in Zimbabwe in 2014. As part of that trip, while I was at Duke for residency, Duke has a presence at a hospital called Moi Teaching and Referral Hospital in Kenya. It's in the city of Eldoret, which is here on the map. It's kind of northwestern Kenya. So they asked us to stop by because they were hoping to increase their radiology presence at that hospital. So we made a short 3-day trip there on our way back from Zimbabwe. So this is a hospital there. This is Moi Teaching and Referral Hospital in Eldoret, Kenya. The AMPATH, or you can see here, the AMPATH building is an organization that was initially founded to help with the HIV epidemic. But this referral center is the second largest national referral hospital in Kenya, the biggest, and the other one being Kenyatta. It's an 838 bed tertiary hospital. There are surgeons there, various specialties there. There's a university there with undergraduate education, which are medical students essentially, and various residencies. And they actually do have a 6-bed ICU at this hospital. So this is Kenyatta National Hospital in Nairobi. And this is their ICU. And in Eldoret, I mean, this is, another large national referral center. This is what the ICU looks like at Moi Teaching and Referral Hospital. But most of those critically ill patients are on the medical ward. So although this is a referral hospital, there's still a lot of need there. So a lot of patients are 2 or even 3 to a bed. The first time I went there, I thought it was visiting hours, but they were actually multiple patients in each bed. And then also is a place where a lot of sick people can be found. This is an example of what the medical records situation looks like at Moi Teaching and Referral Hospital. So just to give you a sense of, how tough it can be to do research in an environment like this. But there are records being kept, which is a plus. So this is the group that I met back in 2014. These are some of the radiology residents. They're called registrars. And many of these residents have now become attending radiologists in Kenya. This is Dr. Tom Hash, who was the attending I went on the trip with. And a lot of these people are folks that I still keep in touch with frequently. So this was the group that made me want to start working there more extensively. Because at the time there was only 1 or 2 radiologists there at the time. And I saw an opportunity there to kind of learn from them, learn about the diseases there, and also provide some teaching and some insight from our side. So there are many residency programs at MTRH. By 2016, there were actually 8 attending radiologists associated with the hospital, 3 that were employed by the university and 5 employed by a private group. And they had multiple sonographers and technologists that worked in their department at that point. They have ultrasound capabilities with very talented sonographers that regularly provide interpretations of ultrasound. They have 2 CTs now, a new 32-slice scanner that actually does beautiful imaging, and an older scanner that they use for kind of emergency room type cases. They do radiographs. They have a new digital mammography system that they're trying to use more and more frequently. And they actually do have an MRI that's 0.4 Tesla, which for me was a challenge trying to read on because I'm not used to that, but it's definitely useful. They also installed a PAC system in 2016. So as far as their residency training, just to give you guys a background, the registrars complete a clinical internship and then they work for 3 years as general medical officers before residency. And oftentimes they're stationed anywhere in Kenya, out in the districts, kind of the front line and sometimes the only medical provider. So this is after their intern year. So a lot of the residents couldn't believe that I've never done a C-section by myself because they've done hundreds as medical officers after they did their internship. Then they do a 3-year residency at MTRH. As of 2017, there were about 6 to 10 in each class. The first year at MTRH, they learn anatomy, imaging techniques, and physics. And then they start taking call second year. So they don't really learn, at least in the prior setup as of that year, they didn't really learn a whole lot of imaging pathology before jumping into call. They do have a few months of elective time in their 3rd year. Many times they'll go to Nairobi or elsewhere to do electives in nuclear medicine often and things like that they don't get to see there. They also have to do a thesis defense, and there aren't any fellowships at MTRH, at least not currently. So when I was doing my clinical rotation with them in 2016, just to give you guys a sense of what I did as a resident for a few months, we would start with case conference in the morning. Sometimes I would present for them, or we'd do multidisciplinary conferences. In the morning, I would be helping out in ultrasound, doing readouts with the registrars, or mounting with my colleagues in the ICU, looking at films with them kind of in that ICU. And in the afternoon, I would do a lot more ultrasound. We would do some CT or ultrasound guided procedures. When I was there for those 2 months, the CT scanner was actually down the whole time I was there, unfortunately. And then do more readouts, and then programming with where I stayed was the Indiana University House, which is houses Americans and people from other countries pretty much year round. Around at least 50 people are there at a time, I would say. This is the reading room back in 2016. So we were doing classic light box reading and writing our own reports by hand that were later transcribed. So just give you a little bit of background about IR in resource limited settings. So, I believe that IR services have a lot of useful applications in these environments, but there's a lot of limitations, including access to expensive equipment, expensive supplies that are usually disposable. And this precludes these from being offered in a lot of places. So at MTRH, 2 radiologists there have now started a burgeoning IR practice, and it is growing rapidly. And they've started using some creative methods for providing and performing these using what they have available in the city, and this could be applied to other places, I believe. So by 2017, and it's been really interesting to get to see, the radiology department kind of grow over these past 5 years. They had 2 consultant radiologists, which are attendings there, and who are performing minimally invasive image guided procedures. One of them, and that's the guy here on the left, he actually fellowship trained and did residency in Alexandria, Egypt. So he's IR fellowship trained. And then Cornelius was a registrar at MTRH, and he's a really smart guy who's basically just has an interest in IR and is learning on his own and learning from Daniel how to do these procedures. So are the hardest working doctors in Eldoret, in my opinion. They're working till 10 p.m. every night, going around to all the different hospitals and doing procedures on anybody who needs them. So they stay very busy. I think the growing demand might be related to the new CT scanner and also the scanners at the other hospitals in the area. And that enables detection of masses, fluid collections, other things that need to be treated with IR. So they do have access to ultrasound equipment pretty readily. Most of their procedures are performed using ultrasound only, and they have good equipment for that. They use radiography, or sometimes, at least in MTRH, there's an outdated but functional fluoroscopy machine that you can use to obtain some post-procedure images if you need to. So they kind of make it work that way. They occasionally do CT-guided procedures if the scanner can be used. And they have been working the last time I was there. So in general, in Eldoret, the patients are responsible for the cost of purchasing the supplies needed for the procedure, such as biopsy needles. So that can be very prohibitive for a lot of patients. So actually some of the equipment has to be reused. So they really meticulously clean it with alcohol solution, because otherwise these patients wouldn't be able to have a procedure at all. So that's something we wouldn't normally do in the States, but this is a situation that's different. And they have to, try to do what they can to help treat their patients. And then at the private hospitals, patients are usually paying a fee up front for the procedure. Although I will say the private hospitals, these patients aren't rich by any means either. It's just, they have some money compared to the patients that usually go to the public hospital. So sedation, if they use it, is usually administered by a physician. Sometimes, usually a nurse is present. The registrars will often help out with the procedures, and they do have a rotation with the IR service where they're learning about procedures. And many of the patients do have a post-procedure visit with the interventional radiologist, so they are providing some longitudinal care, especially if a drainage catheter is placed. They'll, have them come back, evaluate the function of the tube, like in an abscess drain, see how much the output has been, and make sure it's still working for them. So these are some of the procedures that they're commonly performing in Eldoret at both MTRH and some of the private hospitals in the area. So they're doing lots of percutaneous biopsies, abscess aspiration, and drainage catheter placement. They're placing central venous catheters, usually ultrasound guided, and then confirming with radiographs. We did entirely ultrasound guided percutaneous biliary drain placements and nephrostomy tube placements. So here's an example of a case that we did where we, fluoroscopy would have been obviously helpful in order to place this tube. So this was a patient with hydronephrosis that was referred to IR for a nephrostomy tube placement using ultrasound guidance. So we actually placed the tube under ultrasound. It's tough to see exactly where the tube is terminating using just ultrasound, especially depending on body habitus and certain things like that with just ultrasound. So the patient experienced bloody output from the tube for over 24 hours following the procedure. So we brought the patient back and did some limited fluoroscopy using the unit that they have. And this showed here that the tube was actually coiled in the proximal ureter, and that explains the bloody output from the tube. So we were able to, this is Cornelius, Dr. Kipchircher here, and one of the registrars doing fluoroscopy on their machine that they had there. And they were able to successfully reposition that tube into the renal pelvis, and the bleeding resolved. This is another example of an ultrasound-guided drainage catheter placement. This is a very sick lady that came from the city of Kisumu, which is on the coast of Lake Victoria. She has a history of cervical cancer and had undergone radiation, who presented with lower abdominal pain and fevers, and she had an MRI done which revealed pyometra, so pus within the uterus. And you can see here pus-filled uterus with layering debris. So we actually performed an ultrasound-guided transabdominal drainage catheter placement. So placed the catheter through the uterus under ultrasound and got 30 milliliters of frank pus out of there, which worked well for her. You can see where, we do a sterile field, prep with betadine, kind of all those things. And then we also did ultrasound-guided biliary drain placement. So this is a patient with severe biliary ductal dilatation. You can see here on the color, these are all dilated bile ducts here. This is the left hepatic lobe here. So where we're able to access one of these severely dilated ducts under ultrasound, there's our needle entering the duct. And, the interventionalists there have really amazing ultrasound skills. They're actually able to watch as they place the tube into the common bile duct, the CBD, under ultrasound, and confirm that the tube was placed appropriately. So that's certainly something that in the United States, I've never done it with only ultrasound, and I was pretty impressed that they were able to do this only with ultrasound. And then we also do, when I was there working with them, we were doing some tunnel dialysis catheter placements. So this is all ultrasound guided. They only have one size of line, so basically you have to make it kind of fit the size of the patient that you have. So you have to, here they are kind of selecting the tract or the tunnel length here. So ultrasound guidance, this is our probe with the sterile glove being used as a probe cover, kind of picking out the length of the tunnel, doing everything under ultrasound. This is after the tunneling process here, and then confirming flow. And then we checked the flow, checked the position of the catheter using X-ray after the placement. So overall, as you can see, an array of interventional radiology services can be provided in resource-limited regions by maximizing ultrasound guidance, ultrasound-guided procedures, and really only using fluoroscopy or radiography for confirmatory imaging. There are many, many places that have access to ultrasound and will not have a C-arm or an angio suite, but our procedures, and our skills can still be used in these environments. This may deviate from some IR standards of practice in other environments, such as in the US, but I believe that they can be safely performed by skilled practitioners, and that can improve the healthcare that's available to populations in these regions. So just have to be a little bit creative about, when you don't have maybe all the equipment that you're used to having here. So some of the challenges of IR in Kenya, there are only a few radiologists, period, in the region to staff many district hospitals. So there are 3 radiology residency programs in Kenya, but there are, they only have a few rotations. There's no dedicated IR fellowship, so their experience with these procedures is limited, and they may not feel completely comfortable with them. There's no opportunity for IR fellowship currently for training locally. So a few people may pursue this in Northern Africa, like Dr. Chipster. He went to Egypt for his training. South Africa has fellowships available, and in Europe or Asia are options as well. But that definitely makes it a challenge and stressful for families to have to think about going to get training in another country to learn anything about IR. Equipment, availability is limited. Many of the district hospitals may only have ultrasound and radiography. The supplies are expensive, and that is a difficult problem. And there's limited availability of procedural room space, support staff. All of these things can be limited. But there's a lot of opportunities here to expand what IR can do in environments like this. So we can do what we can to help enhance interventional radiology education with the residencies in Kenya. So that way, some of the general radiologists going out there and serving the population will be a little more comfortable performing image-guided procedures. And also something that maybe not so much in Kenya necessarily, but especially in other countries in Africa, like I've done a little bit of work in Malawi, something that might want to be considered is educating non-radiologist healthcare providers in district hospitals that may not have a radiologist, or one that doesn't, may not have time to perform these procedures. So for example, in Malawi, they only have one radiologist in the capital city. And I might be going sometime soon to teach a urologist how to place nephrostomy tubes. So we got to make use of the people that we have on the ground to kind of help some of these procedures be offered to the population. There is an opportunity to develop a IR fellowship in Kenya, which I'll get into in just a second. Many procedures can be performed using only ultrasound or radiography, as we talked about. So we could develop some learning materials related to these techniques to kind of help those that maybe are working in these circumstances. And also, I think there's a lot of opportunity for IR to do a lot of good as far as reduced recovery time, reduced hospital stays for IR procedures compared to open operations that can improve access to care for a lot of populations. So as far as future directions go in Kenya with respect to IR, to collaborate with interventional radiologists to find ways to expand IR services. So cost-effective ways to perform common procedures, like thinking about, for example, if we were doing a urinary embolization, could we use a 5 French glide cath instead of using a microcatheter to perform the embolization and save money that way? And also thinking about how to get around some of the logistical challenges in some of these settings. I think we could, be helpful collaborators in that respect. So I'm at UNC now. A lot of my prior work was through Duke, but so we're actually collaborating with RAD-AID with some interventional radiologists based in Nairobi to provide support for the development of a sustainable IR fellowship in Kenya. And that'll be the first of its kind in that region. And we're hoping to provide education support with lectures and simulations, things like that. Dixon, he's one of my colleagues, and Dr. Bagori visited the University of Nairobi in 2018. They did lectures for the residents. They met with leaders in IR and diagnostic radiology. They observed IR cases and attended and they completed an IR readiness assessment, looking at the equipment, the supply chain, personnel. So basically they're working on curriculum development for a fellowship and also the application process for that, with the hopes of getting that up and running sometime soon. We are planning a visit in July. Andrew Kesselman's going to be joining us from RAD-AID to do a symposium with lectures, some hands-on labs and simulator experience for the residents. And then hopefully in October, doing a little bit more with education, case observation, and possibly an IR nursing readiness assessment. And hopefully providing observerships for some of these trainees in the US sometime soon. This is a slide that one of the MTRH residents put on a presentation that he was giving while I was there about IR, and I think he just did this just to entertain me, but I loved it. I thought this was hilarious, but he knew I would enjoy that, I think. And so just acknowledge a few of the people that have helped out along the way, especially these two down in Eldoret. And thanks a lot.
That was very interesting. Do you know if Dr. Dixon, or have you guys heard back yet about the curriculum? Because I know he submitted it a couple months ago.
I'm not sure if he's on the line. I know that's still in progress, but I would have to ask him about the exact status of that. Yeah, but as far as I know, it's still going forward.
Awesome, awesome. Yeah, that's really exciting.
Yeah.
All right, then I'm just gonna take over. Should we? I don't know if you guys want to now, or should we do, I think the idea was to do all questions bundled at the end. Is that right, John?
Yes.
Okay, great. Then I'll take over from here. You guys can hear me okay and see my screen?
Perfect.
Great. So I'm Fabian. I'm a third-year IR resident, and I'll be talking about the Tanzania Interventional Radiology Initiative, also known as Road to IR. And first, as a little disclaimer. So, like I said, I'm a lot of prep. All the stuff that I'll be talking about is really stuff that I and other residents sort of just came up with as we went along. Another thing I wanted to mention is, for anyone who doesn't know, this podcast called The Sound of IR, you should really listen to that. And there's one episode in particular on the history of IR with Dr. Katzen, which is really fascinating, talking about the history of interventional radiology in the US. And I just found that really interesting because I actually see a lot of parallels to sort of what we're going through in Tanzania right now. So if you listen to that episode and you think that's cool, then you should probably consider doing some IR outreach work. So I'll be talking about the background of our project and the plan going forward, the plan that we came up with based on this background, then the way we've been executing so far, and then who's been contributing to this. So world population today is around 7.7 billion, and according to the WHO, about half of those people do not have access to proper medical imaging. And that's just any imaging. So how many do not have access to interventional radiology, we don't know exactly, but it could potentially be up to 6 billion or maybe even more. And we're actually working, a resident from Yale that I'm working with is actually working with the SIR and finding out that exact number, or it's not going to be an exact number, but more exact than we have now. So we're going to send out surveys to different countries and try to find out which countries have interventional radiologists, which countries have training programs, etc. So I'm going to be focusing in on Tanzania, which is right next to Kenya, which we just heard about. It's an East African nation, probably best known for Zanzibar and its national parks and Mount Kilimanjaro, and has a population of 50 to 60 million people. And our partner hospital is located in Dar es Salaam, which is Tanzania's largest city with about 5 million people. So this is one of the hospital buildings. In total, that's a 3,000 bed hospital. It's the largest tertiary referral center and academic teaching hospital in Tanzania. It's actually sort of the only real academic teaching hospitals, at least at that scale. And so that's one of the buildings here. And here you see the number of diagnostic radiologists in Tanzania. So from 1960 to 2015, that number has increased, which is great. So right now you have about 50 radiologists for 50 million people. That means you have 1 radiologist per 1 million people. And that's extremely low when you compare to the US, where we have about 100 radiologists per 1 million people. And you see how that compares over here. So didn't forget to put that bar here. It's just so small that you can hardly see it. So that's 0.1 radiologists per 100,000 compared to almost 12 per 100,000 in the US. So that's pretty crazy. But what's even crazier is that there's not a single interventional radiologist. So 50 million people, not a single interventional radiologist, nobody that can place a drain, nobody that can put in a nephrostomy tube, nothing. So in 2017, I went to Tanzania for the first time and did a readiness assessment to basically see whether IR would, be possible there. And I found that indeed it should be. So there are several CT scanners at Muhimbili National Hospital. There are several fluoro units, ultrasounds, there are pathology and laboratories. Surgical equipment is available. And most importantly, there's a large diagnostic radiology residency program with up to per year, but there's no subspecialty training whatsoever. So based on these findings, we came up with the following plan, which first includes improving facilities and equipment, especially there's a lack of disposable IR equipment, of course. Then the training of nurses and technologists, because as everyone knows, you can't run an IR procedure without having a nurse and a technologist.
Hello, Fabian?
Yes. Yeah, can you hear me?
Yeah, we can hear you now. I think
All
you
right.
disconnected for a moment.
Yeah, some of my connection is pretty bad. So I'll just keep going. Where did I cut off? Was it
I
before?
believe- Yes.
Like here?
Yep, sounds good.
All right. Yeah, so basically, so the plan includes like facilities and equipment, training of nurses and technologists, and then the training of residents. And so we're doing this by sending 10 to 12 teams per year from the US to Tanzania. So we started off last year in October with a team from Yale, and then in November, a team from Emory went. This year in February, a team from Utah, and right now, a team from Emory is there. And then we'll just continue throughout the year. So people going from Kansas, Yale, Emory, Cornell, New Orleans, and even New Zealand. So this is what the 2-week schedule for the visiting teams look like. So most teams go for 2 weeks. So usually people get there on a Sunday, they get picked up at the airport and get a little orientation to where they'll be staying. Then Monday through Friday is pretty much the same way that an IR service here is run. So it starts off with a morning case discussion. And then throughout the day, people do procedures and give lectures if there's time in between procedures. Then the weekend, people usually go to Zanzibar or to one of the national parks for safari. Second week goes back to the same schedule as the first week. And then the last day, and that's important, is actually reserved for a conference call with the next incoming team. So like I said, we have a team going every month. So then at the end of their 2-week stay, they're going to hand off to the next incoming team, which comes about 2 weeks later, so that there's a continuous handoff. And for the actual practical training schedule, we proposed a 3-phase approach, starting off with procedures that are immediately needed. So we started off with abscess drainages, nephrostomies, biliary drains, and core needle biopsy, because we felt like those were the most urgent. And then we actually this week sort of stepped up to phase 2, which includes basic vascular procedures. And then by next year, we hope to move on to complex vascular procedures, including neurointerventional radiology, interventional oncology, and things like uterine fiber deembolization. And now I'll talk a little bit about how we've been executing this plan so far. So like I said, we started off last year in October. So here are pictures from some of the incoming teams arriving in Dar es Salaam, coming from all over the US. This is some of the equipment that some of the teams brought along. And this is the very first class of Tanzanian IR residents. So they are my peers. They're currently 3rd-year radiology residents. So they're done with their diagnostic training this year. And then they'll be doing full-time IR for 2 years. So this is Eric, Ivan, and Aza. And this is from my first visit in 2017. And you can see here, Eric is holding a self-made CT biopsy grid. So this is actually made from chicken wire. When we got there, they didn't have any grids. So we figured we can at least try to do something to do biopsies using this. And we've come a really long way since then. So now you can see everyone has LEDs that we got donated from Burlington. This is Dr. Prologo here from Emory. With the Tanzanian residents, so some 3rd-year residents and some 2nd-year residents over here. Like I said, we're bringing nurses and technologists. So these are some of the visiting techs and nurses with their Tanzanian counterparts. A huge part of the teaching there is actually case selection, just because these procedures are new for the Tanzanian residents. So just finding out what is appropriate for IR and what's not, and also educating the referring services about what IR can do and can't do. This is what it actually looks like in the procedure room. So I think this is during a biliary drain. You can see there's a lot of interest, and usually there's at least 15 people in the room, so it gets pretty crowded. This was the very first corneal biopsy we did. So Dr. Sillen's wife actually hand-delivered the specimen to the pathology department. By now, the Tanzanian residents do corneal biopsies themselves, even when there's no visiting faculty around. So you see here Eric biopsying a posterior rib lesion. Here, Eric is seen draining an abscess, and these are visiting faculty from Emory and from Utah. Here they're placing a biliary drain, and this is Aza putting in bilateral nephrostomy tubes with Dr. Koch from Utah. And this week, actually, like I said, we moved on to phase 2, so starting some basic endovascular procedures. So here they're placing a central line 2 days ago, and then this was actually just yesterday. They did the first complex vascular procedure, or more complex vascular procedures, a pancreatic pseudoaneurysm embolization, which worked out fine. So that was a great success and really a milestone for the program. So this data is of last week, so I haven't included the vascular procedures yet. So by now we've probably done about 60%. But as of last week, we've done 52, including 21 corneal biopsies, and 7 of these procedures are follow-up procedures, so like internalization of drains, for instance. 96% of procedures were technically successful. We haven't had any major complications so far. And from the 15 corneal biopsies that have resulted so far, 100% were diagnostic. We do a pre-procedure survey with all patients just to sort of find out, where they come from, what their background is, and to see, how we can best adapt and expand our IR service. So this actually demonstrated that most patients are not that far from the hospital, which I thought was great. I was worried that people would travel really far, but this maybe also because the program is new, so it's mostly people from the city that are coming. Interesting also here, the referral patterns. So most of our patients, maybe not surprisingly, come from surgery, 40%, and 21% from general practitioners, and some from medicine. Also, we asked them about who's paying for the procedure, because we wanted to know where people get the money from. And actually, half of patients have insurance, so that's great. But about 1/3 are self have exemptions. And we asked them how they want to follow up. And this also surprised me a little bit. Only 2% would prefer in-person follow-up, and 94% of patients would prefer to just follow up with a phone call. So that's when we asked them before the procedure. We do follow-up via phone call now at 1 and 3 months. Eventually, we're hoping to switch to a text message follow-up system so that the residents don't have to make all these phone calls at 1 and 3 months. But so far, that's what we're doing. So we have a post-procedural bleeding or infection in about 10% of patients, but all like just minor bleed or a little infection, and nothing bad. No reported major adverse events. 96% of patients were overall satisfied with the procedure. The few that were not were the ones that were technically not successful, and that was usually due to a lack of a specific piece of equipment. And then after the procedure, about 12% actually wanted in-person follow-up. So when we do this initial follow-up, the reason is also to sort of filter out, or screen for people that then want to come back and that want to be seen in person. And so there's a lot of people involved in this project, and institutions. So mostly I wanted to mention Muhimbili, of course, Yale and Emory, but then also German National Academic Foundation, Doximity, Rad8, SIR, Burlington, and Cook, who've all contributed to this project. There's a lot of people on both sides of the Atlantic that I wanted to mention. A lot of people, of course, from Muhimbili National. They want to thank the Tanzanian residents, Eric, Ivan, and Aza. and they're sort of really my partners in this entire project. Like we make all decisions together, and like I said, we worked out this plan together. And then I wanted to thank some people from Yale, in particular Frank Minja. Can you guys see me?
Yeah, Fabian.
I cut
think
off
some
again.
people were cut off. I think some people were cut off the last few slides on audio or video. If you could just,
All
and
right.
that would be great. Yeah, thank you.
So Rob, I think you just have to select yourself as presenter now.
Can you hear me? Can you guys hear me?
Yeah.
Yeah.
Okay. Let me. Alrighty. Oh, then I select myself, organizer, me. Okay. Give me a second.
Yeah. So put the little screen.
Give me a second. Show my screen.
Yes.
You guys see?
Yep.
Okay, let me just minimize this. All right. Hey, thank you for the invitation to participate in this webinar. My name is Rob Peng. I am a PGY4R3 at Montefiore Albert Einstein in the Bronx. And I'm going to just talk about my experience with interventional radiology in Ghana. So as a second year, I had the opportunity to go to Korlebu Teaching Hospital, which is in Accra, Ghana. And this is the third largest hospital in Africa, and is the largest tertiary referral center in Ghana. And I guess just before I even talk about this experience, a little bit about myself. I always had an interest in global health. I did some work as a medical student in China doing research in Beijing Cancer Hospital. And when I heard about what Radied was doing, I knew that that's something I was definitely wanted to be involved with. So as a first year, I formed the Radied chapter of my hospital, and I really got involved with the Ghana program. And interestingly enough, in the Bronx, we actually have one of the largest populations of Ghanaians outside of Ghana. So it seemed to be the perfect fit. And I heard about this one guy, this one interventional radiologist in Ghana, and I knew that he's someone that I really, really wanted to work with. So now coming back to Korlebu Teaching Hospital, it's a 2,000-bed facility. They do have a residency program with 11 radiologists, and they currently have 18 residents, anywhere from 3 to 4 a year. I'll talk a little bit about the angio unit that they have, but just to give it, but they also have 2 ultrasounds, 2 CTs, one of which is a 640 slice CT, which is actually perpetually down. They have 2 1.5 Tesla MRs, one of which is down. And they also have a fluoroscopy unit. So this is the entrance of Korlebu Teaching Hospital, and when I saw this, I thought it was beautiful, to be honest. And a lot of the hospitals just open, and you walk from building to building. But this is just to paint the picture a little bit. Here is a small, quick walkthrough. This is my first walkthrough. Hope everybody can see this video through the hospital. Okay. So here's a team. So on the left, that is me and my co-resident. So I brought a team of me, my co-resident, 2 technologists, and the entire team is this right image over here. There's Mac, one of the IT personnel, trying to take a selfie while we're taking another picture. And going back to the left image, those are some of the radiology residents, with the tallest person being the chief resident. And in addition to doing IR, there's many different teams that were part of this single trip. My co-resident, she was involved with a lot of the, she gave a lot of lectures, and she also performed a readiness assessment of the current state of affairs in Korle-Bu Teaching Hospital. But we also were joined with IT personnel, technologists with regards to, I guess, MR technologists, CT technologists. We had a biostatistician with us. We had another technologist, educator with us. So a huge component of the trip is just education. This over here, the man to the far left, he is Chip Sweat. So he's one of the RAD directors. So he's giving a lecture to the radiology residents. On the right is, I think this was like a plain films rotation, or where they have, you know, this sort of on-site three residents and attending teaching. So it's pretty interesting to see. And they're all trying to look at these images and decide, and they're all extremely bright and they know a lot. So now going to IR, I had the opportunity to work with Dr. Benjamin Sarkody, and he is the only interventionalist for 26 million people. And I was astounded when I heard about that. And he's really trying to develop IR in his country, and he established the Ghana Society of IR. He works at Korle-Bu Teaching Hospital, but he also works with other private facilities just because he's the only one doing it. So he's running around doing what he can in the country. So there's me and Dr. Sarkody, and then on the right, the guy in the blue, he's Ben, and he's a nurse that is trained by Dr. Sarkody. So the current staff that he works with is, he has Ben, who is the nurse, and then he has the technologist as well that he's trained. Everybody does a little bit of everything because it's just them. That's a department. That's a section. Here is the biplane unit that they use, that they share actually with the interventional cardiology. So there is no DSA here. There was no power injector, so everything was, we used hand injections. And, that said, they do amazing work with what they have. Let's see. Here is a picture of me. I think we're doing a taste in these pictures. So they're really doing a lot, like a full breadth and depth of what IR has to offer in this country, and I was really, really impressed. So just to give everybody an example of what they're doing nephrostomies, angioplasties, UAEs, nerve blocks, biliary stenting, abscess drainages. While I was there, I saw blind embolizations, I saw TACEs, I saw UAEs. But I remember there was one patient that he was bouncing around from physician to physician with intense multiple filled courses of antibiotics. And then when we took a look with ultrasound, we saw this huge abscess. So Dr. Sarkody put in a drain, and in this country, this guy would have needed an open procedure. So things that we consider IR light, that we kind of aren't so impressed with. It's these are extremely, extremely impactful procedures. And Fabian, that's one of his focuses in Tanzania. It's definitely, I think by going on some of these trips, it gives you a lot of perspective. The things that are important in our society versus their society are extremely different. While I was there, I also traveled maybe 6 hours north by bus to Komfo Noche Teaching Hospital, which is in Kumasi. And this one was the second largest hospital in Ghana. And a lot of this trip that I went on was really to establish new connections and to see if there was a role for IR in these hospitals. And I met with Dr. Amangpa, who is extremely interested in IR and the possibility of IR for his hospital. So right now, I think most importantly is education, education, education. Most residents, most physicians there, they have no idea what IR is. So ideally, if these institutions participate in the global IR webinar lecture series, that would help them in that regard. And Fabian and Yale's leading that effort. For any attendings that go there, we definitely need hands-on workshops and just specialty lectures. And also, it's particularly important to lecture to the other departments because really, to be honest, no one knows what interventional radiology is. For the future, with regards to administrative goals, we'd like to perform, we would like future volunteers to perform updated IR readiness assessments that really look at supply, safety, and personnel to any potential IR site in Ghana. Additionally, a lot of it has to go through, for IR to really happen, our goal is to meet with the Ghana College of Postgraduate Training to have that initial conversation so they know what IR is and to kind of get their approval to support this. Additionally, in a country where IR really is in their infancy, you know, there's this issue of credentialing. You know, if you see one, do one. Some people may actually go out and do one after seeing it just once. So that's a huge fear of Dr. Sarkody's. And that's something that, you know, accreditation is something that we're definitely trying to work on. And also, we want to focus on the development of a better case log system. They're in a system where there's absolutely no EMR. Case logs is extremely difficult. And in this country, even an ID is difficult. People travel from all over the world, all of the country to Korlebu, and they may spell their name differently, or they may not know their date of birth. And these are issues that I didn't anticipate prior to my going on this trip. With regards to the support staff, he has a single technologist, a single nurse, and I could not begin to ever think that I know how to do a technologist's job or a nurse's job. So in the future, we'd like to bring you know, a dedicated IR technologist and dedicated IR nurse to give them some more specialized training. And a large problem is these issues of consumables. A lot of what Dr. Sarkody does and what he works with is comes from donations from different companies. And like Dr. Stewart mentioned, a lot of his patients, just because they can't afford it, he will reuse a lot of his equipment. In the event that they can't afford to pay for it. And this is just what it takes to provide care for these patients. And he uses also an alcohol-based solution. So there's also this issue of expired consumables. A lot of the consumables that we use in the US really, if these consumables can't be reimbursed, they're thrown in the incinerator. So countries like this may have good use for them, but at the end of the day, that's not really sustainable with regards to supply chain. So we're exploring new venues to get consumables to these countries. So this was just a little rundown of my experience in Ghana, and you know, in the future, at the end of the day, our goal is to develop IR sustainable fellowship in Ghana. And I've been working with Dr. Andrew Kesselman of Rite Aid for this. We want to develop some more education support. His goal is to kind of go there and give a symposium on IR, have some hands-on lectures and simulations. And again, we do need volunteers to go to different sites to perform updated IR readiness assessments. And really, you know, I encourage all medical students, residents to reach out, because in this country, IR really is in its infancy with only a single interventional radiologist in the country. And it's an invaluable experience where you really do get to see the impact of IR in a world where it's just starting. And again, things that we consider IR light, abscess drainages, biopsies, these are life-saving in these countries. And it was extremely invaluable experience for me. So if anyone is interested in learning more about what's going on and what we're going to do, please feel free to reach out. Thanks for your time.
All right, and with that, we have all three presentations. Thank you to the presenters. Those were very informational and great presentations. At this time, if anyone has questions, please feel free to enter it into the chat. Then we can have the panelists and speakers answer. But just to kind of, I guess we can ask one simple question, sort of re-engage the question of how to get more students involved. So there's the aspect of traveling abroad and volunteering and getting engaged that way. Are there opportunities for student or resident involvement while in the US in helping organize these efforts, or kind of doing research into these different kind of avenues of getting IR out in terms of education or outreach? I can start with any of the panelists.
I think there's huge opportunities for this. You know, from developing educational materials that could be used, you know, helping develop web lectures. I mean, there's tons of ways, especially with modern technology, that you could get involved without ever leaving the U.S. with increasing education, you know, in these other areas.
Yeah, I totally agree. And also, you know, with the research aspect. So actually, there's, you know, already like 5 or so medical students that are working with Anish and I from Yale on the Tanzania project. And, you know, some of them are planning on going there at some point, but, you know, for people that, you know, don't necessarily want to go there, you know, there's still a lot of ways to help out from back home.
Yeah, I completely agree. You can reach out to any one of us, but also if you look at the Rad Aid, there's the medical student section. They actually have a great curriculum for global health. I think that really is a great start because after you do that, they really do plug you into different programs. And there's definitely a role for medical students.
Follow-up question, sort of in a different area, but I guess there are some unique challenges that are being presented at different sites, and how, you know, these problems kind of interface with the culture of these different sites that you're attending or volunteering at. Are there opportunities for innovation, and how can you sort of engage the IR community in taking part of that, like, you know, whether it's biodesign or for medical devices, or, you know, improving on procedures? I know Dr. Stewart earlier was saying that making educational material that may focus more on the ultrasound aspect instead of having follow-up CT or radiographic confirmation might be an area where we can find some improvements in the field. If you could just weigh in on that.
I think there are huge opportunities for biodesign, device development in this realm. So there was actually, when I was a medical student at Stanford, there was a course that focused specifically on that, which was designed for resource-limited regions for medical devices. They developed, I believe it was a battery-powered baby incubator. They developed a inhaler that was basically made out of a folded piece of paper, like a spacer for an inhaler, rather. So I think there's tons of opportunities for innovation for low cost, like the reason being low cost, that would be appropriate in some of these settings. And I think that could certainly apply to IR as well.
And one other thing, not just innovation, but I think we also have to take advantage of, you know, globalization. So now you can, you know, go on Alibaba and order IR equipment. So we actually, just a couple of weeks ago, got the first shipment of IR equipment from China. Ordered 500 biopsy guns for $2,500. So that's $5 per biopsy gun. And, you know, the quality is not as good as if you would get it in the US, but it's, you know, like almost as good. And it's for an eighth of the price. So here, if you buy a biopsy gun, it's over $40. And like we got them for $5. So I think that's something that has a lot of potential, you know, ordering stuff from China and India.
That's great.
I don't see any further questions in the chat. Are there any closing comments you would like to make before we finish out the webinar?
Yeah, since I was cut out earlier at the end, like the only other thing I wanted to say is, that like Rob was saying also, that there's a ton of opportunities for students to get involved, and like we actually on most trips bring a medical and or a resident. So and our entire case log system and like the pre and post procedure service, that was all built by medical students. There was a medical student from Germany that came with us, and he built that entire system in Google Docs. So without this medical student, we wouldn't have all the data that we've collected so far. So even for medical students, they can help a lot.
Yeah, I completely agree. I think that, to be honest, everybody here is doing amazing work, and it's an honor to work with everybody here. And it's really a small group of people who are willing to kind of put themselves out there in these different countries. So you really, when you participate in a trip, you really just join this huge family, and everybody's willing to give you any sort of support or advice that you need moving forward. And it really almost is like a grassroots approach to developing IR, because as soon as you go there, any sort of idea that you can think of, any innovative idea, everybody's on, people are very receptive to that. And I actually met Fabian through I guess I work in global health, and we actually have become good friends, and we kind of bounce ideas off each other all the time. And there's possibility I may go to Tanzania, and it's these sort of connections that will help really bring IR to these developing countries.
Dr. Stewart?
And I just wanted to also plug in, so for people interested in outreach stuff, also consider the outreach committee from the RFS for those that are not in that already. That's being led by Andrew and Rajad right now, and that's a good way to get organized and help out with outreach projects. So there's the outreach committee of the RFS, and then of course there's RAD8. So those would be really the two organizations that you should look into.
And just so people are aware, this, in addition to Ghana and Tanzania and Kenya, there's also development programs in Nigeria, Ethiopia, Vietnam. If there's any other places that medical students are particularly interested in, it's reach out to any of us, and we can tell you how best to get started.
Alrighty, and with that, we'll conclude the Interventional Radiology and Global Health lecture. Hopefully we'll have more to come in the future. Thank you everyone, presenters and audience alike, for participating. We'll see you next time.